As usual, we are going to have our part 3 regarding abdominal scanning protocol, and this is Dr. Ed. Once again, I still encourage you to subscribe and to like my YouTube channel because these protocols are going to be helping you, more so the students in the imaging course. So today we are going to have a look at the urinary system, then the GIT, peritoneal spaces, and the lymph nodes. Okay, so starting with the anatomy of our urinary system. As we all know that the urinary system is concerned of the kidneys. We can see the kidneys with the ureters which connect the kidneys to the urinary bladder, and then the urinary bladder has its outflow, which are the ureters. So the kidneys are two, and the one urinary bladder, paired ureters, and all of that makes the urinary system. So we are going to look at the sonographic approach to scanning the kidneys, and as we can say, first of all, how do you locate the kidneys? Okay, so if you are a learner, where you go, you just go in the sagittal, subxiphoid window to the level of the subcostal, then you sweep laterally towards the back. Then you may see an image which exactly looks like this one. So in this image, this one is the right kidney, whereas to the left, this is the left kidney. And after getting this image, exactly what do examiners want you to talk about? Exactly, in case you need these notes, you may pause, but me, I'm going to be going to the images strictly. So let us say you've got this image, is nice. So this is a sagittal image of the kidney, whereas this is a transverse image of the kidney. So after getting this image in sagittal, yes, you freeze. Then what you can see here is a beautiful kidney. It has this outermost part, echogenic, which is the renal capsule. Then also we have the renal cortex. Then these hypoechoic areas are the renal medulla. Whereas these hyper-echogenic structures, these are the renal sinuses. So your examiner wants you to talk about the gross parts of the kidney. So you have to say this is the renal cortex. Comparing echogenicities, it is hyper-echoic, related to either the kidney or the spleen if it's on the left kidney. Then the renal medulla is hypoechoic, still relating to either the liver or the spleen, whereas the renal sinuses are always hyperechoic in relation to the splenic or the liver tissue. So again, you'll talk about the pores. Each kidney has 3 pores. We have the upper pole. You can see this cursor. We have the mid pole and then the lower pole. In sagittal, those are the pores, whereas in transverse we have a C-shaped kidney. We can locate the hilum, and that's all what you talk on a transverse image. So whereas when you want to measure, you just measure the length of the kidney from the upper pole to the lower pole. Then you also measure the anterior posterior diameter from across the mid pole. So you cut the kidney from anterior to posterior. Then the other transverse measurement is just from the hilum to the lateral border of the kidney, and and those are the three measurements which they will need you to measure on the kidney. For the values, we know this kidney shouldn't exceed the AP diameter shouldn't exceed 6. The transverse diameter shouldn't also exceed 6, whereas the length shouldn't exceed 13. Okay, so that was all about the kidneys, but again we can also see the urinary bladder. So the urinary bladder, we all know that it is that sac where urine collects before it is passed out. So mainly what the examiners want you to get, one is a sagittal image of the urinary bladder and then a transverse image. So in sagittal, you just get a triangular shaped anechoic structure like this exactly. Then on transverse, this is kind of rectangular structure. So you measure the wall thickness, and after that you may also measure the volume of the collected urine. If the next volume, then still it is on the sagittal image. You take two measurement points, that is from the length, then the width or the AP, then finally you take a transverse diameter. Okay, so that's all what we can see on the urinary bladder. So let's also talk about sonography of the GIT. So the bowels, as we know that they have a variety of walls. So as this diagram illustrates, we can see the innermost walls, that's the mucosa, then submucosa, we have the muscle layer, then also finally we do have the adventitia or the outermost layer. So on ultrasound, this is the signature of the renal bowel. But even before that, this is a gross image for the GIT. We can see the stomach, then we can see the duodenum, which is part of small intestines, and finally these are the ascending, transverse, and then descending colons. I advise the students to always start with the large bowels, but even before that, we should know the measurements for the diameters of these bowels. So as a rule, according to this slide, we should also get that we have 3, 6, 9. So 3 is the diameter for small bowels, then 6 is for the large bowels, whereas 9 is specifically for the cecum. So if you are to start with the large bowels always filled by gas. So the other unique feature is that they have oscillations almost 3 centimeters apart. So what you do, you identify the right psoas muscle around the iliac vessels. So there you slide laterally toward the abdominal wall, that's the lateral side, that's at the side. So the cecum is always there. You see gas-filled structure with the oscillations, and also from there then you start following the ascending colon. Then still you follow the ascending colon to the hepatic flexure. Then there you turn, you follow the transverse colon to the splenic flexure. Then you follow the descending colon up to the point of the left psoas muscle. Then you turn, as you know that the sigmoid colon turns medially around the urinary bladder. Then you will see the rectum also posterior to the urinary bladder in male client, or posterior to the uterus in female client. So this is an image, maybe here where we can see the oscillations. So we can see 1, This is a wall 2, this is a wall 3, and these are the house striations. Okay, and when we're going to the small bowels, it is always better to start with the stomach. The stomach, we do start at the gastroesophageal junction, which is also always anterior to the aorta in sagittal view of the aorta, abdominal aorta. Then there you can also go to the stomach, then you will see its contents. Its wall shouldn't exceed 3 millimeters, so always measure that wall. Using this image, which is labeled A, you can see the aorta. The esophageal gastro junction is always at this point. By then here we can see the stomach, you can see the liver, this is the pancreas, so the stomach is always anterior to the pancreas. So from there you go to the small bowels. Small bowels are just characterized by having the venical veins. Others call them poria sacchularis. So they are always centrally having borders made of the large intestines. So they are scanned also from the side, medial, then to the other side, to always note the diameter and also peristalsis. So this is a sonogram of small intestine. You can see the vena comivents. You can see 1, 2, 3, 4, and this bowel was filled with some fluid, though there are some echoes. So comparing a large bowel, we can see a small bowel with the venicomivents and a large bowel with the house striations. Okay, the other, as we continue following the protocol, the other structures to see are the potential spaces. So majorly we have 5, those are the Morrison's pouch, lesser sac, splenic renal pouch, then you have the right paracolic and the left paracolic. These spaces, in case you need to see these wordings, will be pausing the video, but I'm going straight to the images. Okay, so it is advisable to start with the Morrison's pouch, which is always space between the right kidney and the liver, and in this case you were seeing some fluid which was feeding the Morrison's pouch. It is also called hepatorenal space. Then we also have the left subphrenic space, which is, this is the diaphragm, and so sub below the diaphragm. And we also have the subhepatic, which is space below or inferior to the liver. The other space, we also have the lesser sac, which is, this is our pancreas, and this is the stomach, so a space in between, that's the lesser sac. Whereas we also have the splenorenal space, which is space between the left kidney and the spleen. And we also have left subphrenic space, which is below the diaphragm at the left side. And also we can have subsplenic space just below. Okay, so as we continue other spaces, there are very many. We have the perirae iliac fossa, perileft iliac fossa, the supracolic gutter, infra, rectosigmoid pouch, pouch of Douglas, the vesical uterine pouches. So all these are assessed for the presence of free fluid collections in cases of ascites. So we can see all these was gross ascites. These are the bowels which are appearing as if they are floating in this lake of fluids. So this was a case of ascites. Okay, so for the lymph nodes, I didn't actually put in the sonograms, but If you have been following my protocols from the liver up to where we've reached, then you know these areas. So para-aortic, you just follow the aorta and you look at the celiac trunk, you look at around the superior mesenteric artery, along the bifurcation for iliac vessels, then at the portal hepatis, around the pancreas, around the splenic hilum. So just what you do, you locate these areas and then you tell your examiner that around or up to or below this organ we would see maybe lymph nodes, but this one is very okay. Okay, so after all this, if you are dealing with a client and now maybe there's a practical session, you have to thank the client, then clean the client, then clean the probes, let the client go off the bed, then you clear the bed sheets. Alright, so definitely you have to make a report after finishing any presentation or any practical ultrasound study. So for the report, we'll just maybe in case it is needed, you'll just text and I can just email you how reports are made. So Dr. Edson, as usual, I salute you all. Thank you for watching my videos. Please don't forget to like and subscribe. Next are gynecological and obstetric protocols. After this, I will be posting a series of hot cases, which will be, I hope, beneficial to everybody who will really be or have subscribed to my YouTube channel. Thank you.